Hello, my name's Hannah. I'm one of the CTFs at SWBH, and today we'll be talking about diabetic emergencies. So we'll be talking about the assessment and management of common diabetic emergencies, including DKA, HHS and hypoglycemia. So the causes of DKA will include infection and intercurrent illness, infarction, insulin, incision, i.e. surgery, trauma and pregnancy. The signs and symptoms of DKA include abdo pain, nausea and vomiting, confusion or disorientation, polyuria, dehydration, so you might see some tachycardia, dry mucous membranes and a prolonged cap refill. You can also see a pear drop breath, so this is a sort of sweet scent on the breath, and Kussmaul breathing. So Kussmaul breathing is deep and laboured breathing, and that's because the patient's trying to expel some CO2 and therefore reduce their acidosis. So in terms of our investigations, in DKA we see a hyperglycemia, so a blood glucose of more than 11 millimoles per litre. We see a ketonemia, more than 3 millimoles per litre or 2+ on a urine dipstick. Acidemia, so pH of less than 7.3 or a bicarb of less than 15. Some other important investigations will include investigating the cause of the DKA, so looking for any infection. That might include bloods, cultures, an ECG, septic screens and troponins if we're concerned about an MI. And it's important that we get a detailed history of the presenting complaint and their drug history. For the management, it's really important that we look at the TRUST protocol. But globally, we're going to be doing an A to E approach and resuscitating as needed if the BP is low or the heart rate is particularly high. It's very important to involve our seniors early, whether that's our own MedReg or even ITU, especially if the GCS is low or if the renal failure, the renal system's been impacted. How we manage it, regardless of the TRUST, fluids and insulin will be the mainstay, and it's important that we monitor frequently. So this is just an example of how we, kind of the DKA protocol in trusts. So the way we monitor it is via hourly capillary glucose, plus or minus the ketones. We tend to do a VBG for the bicarb, pH, etc. at 1 hour and then 2 hours, and then usually every 2 hours continuing. The lab electrolytes we can do every 4 hours because we get quite a lot of those from the VBG anyway. We'll be doing regular observations, especially neuro-obs, because there is a risk of cerebral edema, especially in younger people. So the HDU criteria, if they've got ketones above 6, a potassium of less than 3.5, a GCS of less than 12, a bicarb of less than 5, or a pH less than 7.1, or an anion gap above 16. On the OBS, low saturations, low systolic blood pressure, a low or a fast heart rate, and then certain comorbidities such as the very young, the elderly, those who are pregnant, and those with heart or liver failure. Ideally, we'd be consulting ITU before this just to inform them of the patient, but at this point we should definitely have HDU on the phone. So in terms of the fluids and insulin regime, we always need to replace the fluids, so we do this via normal saline, and we give 1 litre in 1 hour, then 2 hours, then 2 hours, 4 hours, 4 hours, 6 hours. So 1, 2, 2, 4, 4, 6 is how we remember it. Now, if the blood pressure is less than 90 systolic, we give 500 ml boluses stat and up to a maximum of 2 litres. So that first line is if they've got a normal blood pressure, normal heart rate, but then we can supplement in some boluses if they are hemodynamically unstable. For the insulin, we give a fixed rate infusion, and that's at 0.1 units per kilogram per hour, up to 5 units per hour. And we never stop the infusion without subcut cover. So even when the patient is resolved and they're back to normal, we cannot stop the infusion until they're kind of established on their normal subcut cover. So some special considerations: once the BMs drop below 14, it's really important that we start a 10% dextrose solution because we risk the patient going into a hypo. We also continue the long-acting insulin even when they're on the fixed rate infusion. We really need to consider VT prophylaxis because these patients are typically dehydrated and are therefore at a much higher risk of a VTE. The potassium, but you might already be aware from our treatment of hyperkalemia that we treat with insulin. So we know that giving insulin decreases the plasma concentration of potassium. So therefore we need to replace it for these patients. Typically we do this in the second bag because the first bag we know is over 1 hour, which is too quick to give potassium. So add it to the second bag. If the patient has a potassium of less than 3.5, we need to be speaking to the seniors because actually we might need to give this potassium a little bit quicker than we can safely. So speak to your seniors before prescribing potassium. If the potassium is in the normal range, then we would give 40 millimoles per litre of normal saline. And if the potassium is more than 5.5, we don't need to add potassium to the fluid, but we do need to keep an eye on the potassium because it might drop quite quickly. So our treatment targets, we're looking for a fall of blood glucose of 3 millimoles per litre per hour, also ketones to fall by 0.5 millimoles per litre per hour, and bicarb to rise over 3 millimoles per litre per hour. And really we want all three of these to be occurring. And we can say the DKA is resolved when the pH is greater than 7.3 and or blood ketones are less than 0.3 millimoles per litre. If we're happy that the DKA is resolved and the patient is eating and drinking normally, we switch them to their usual subcut insulin. If the DKA has resolved but the patient can't eat or has another indication for IV insulin such as sepsis or MI, then we use a variable rate insulin infusion. We always inform the diabetic nurse within the trust about a patient with DKA because it may be that we need to tweak their usual insulin regime to prevent this happening again. So moving on to HHS, it's similar to DKA but has a few key differences. Typically it presents in elderly patients and those with type 2 diabetes, and it usually features inadequate hydration and intercurrent illness. So HHS stands for hyperosmotic hypoglycemic state. So hyperosmotic, we're looking for a plasma osmolality of more than 320. For hyperglycemia, this is usually really quite marked, so typically the BMs will be above 30, but also there needs to be no ketonemia, so a normal cap ketone, no significant acidosis, so the pH should be above 7.3 or bicarb above 15, and then S stands for state in HHS, but I also remember shock, so hypovolemia. So why don't these patients become acidotic? Why don't these high BMs lead to an acidosis as they do in DKA? Well, it's not entirely clear. We think that it's because the insulin level in these patients is sufficient to prevent significant ketosis, but it's insufficient to stimulate significant glucose uptake in the tissues. So as a result, you can get some mixed pictures of HHS and DKA for patients who have fluctuating insulin levels. So as with DKA, the management is fluids and insulin, but the way we give this is slightly different. So in HHS, there's a more significant dehydration, and often this is the cause of the HHS. So we give a much more rapid replacement than we do in DKA. But as with DKA, we need to remember to give the potassium. We start insulin if the BMs are not reducing despite the fluid resuscitation, and we give a fixed rate insulin infusion at half the rate of that in DKA, so 0.5 units per kilogram per hour. So we don't start automatically with insulin in HHS. We start with fluids, we give quite aggressive replacement of fluids, and then if the BMs aren't reducing, then we start the insulin at half the rate. As with DKA, it's very important that we start VT prophylaxis because their risk of clots is much, much higher than the general population. So this is an example of a HHS regime, but again, consult your independent trust. So complications of HHS. So because of the dehydration, they're at a really high risk of VTE. The risk of, rapidly replacing the fluid, so overload if there is any cardiac or renal failure. There's a risk of cerebral edema, electrolyte disturbances and therefore arrhythmias, and central pontine demyelinosis. And this is because we're rapidly correcting sodium. So this may be a complication that we see. So it's important to understand the difference between DKA and HHS. So we've covered most of these, but just to reiterate, the primary treatment in both is very different. So In HHS, we're focusing on fluid resuscitation, whereas in DKA, we need to immediately give fluids as well as insulin. The complications are the same on both, so electrolyte imbalance and cerebral edema, particularly in the younger patient. The monitoring parameters are different. So in HHS, we're looking at the serum osmolality, whereas in DKA, we're looking at the pH, the glucose, and the ketones. HHS develops over a longer period of time, typically days to weeks, whereas DKA is quite quick, so this can be hours to days. In terms of correcting the disease, HHS can take days, whereas DKA will usually see a quick improvement in symptoms and signs. The patient demographics in HHS, it's typically an older patient with type 2 diabetes, whereas in DKA it's type 1 diabetes and often younger patients, but that's not exclusive. The incidence, so HHS is quite rare. We tend to overdiagnose it, whereas DKA is very common, so more than 20,000 UK cases per year. So moving on to our final emergency now, hypoglycemia. Most cases are due to inadequate nutrition or iatrogenic causes. It's important to understand the normal diabetic drug regime for the patient and indication for the dose changes. So we define hypo as a blood capillary glucose as less than 4. And in terms of the symptoms and signs, we can see a tachycardia. The patient's often irritable and restless. Typically, they're very hungry if they're kind of conscious, and we might see a diaphoresis or a depression. Here's an example of a trust guideline on treating hypoglycemia. Again, it's really important to be aware of your trust guidelines. At our trust, we treat mild cases with, the quick-acting carbohydrate. So this could be dextrose tablets or an oral glucose shot. And then we recheck the BM after 15 minutes. If it's still low, we can repeat that for a maximum of 3 times. If the patient is conscious but they are more confused or aggressive, but they're still able to swallow, we still give a quick-acting carbohydrate, but we do this via 2 tubes of fast-acting dextrose gel, or a 60ml oral glucose shot, or a glucagon IM injection. And again, we recheck after 15 minutes and we try a maximum of 3 cycles of that treatment. If the patient's unconscious, they're fitting, they're aggressive, or we're not responding to the mild or moderate treatment, then we need to do an A2E assessment, get the medic on the phone rapidly, so whether that's an EMRT or a 2222. We stop the IV insulin if there is one running, and we give 150 ml of 10% glucose over 15 minutes through a large cannula, and we give it a really good flush to make sure that's all in the system. We consider 100 millilitres of 20% glucose if there is any cardiac or renal failure. And it's important we stay with the patient and that we are regularly checking those BMs. Glucagon IM injection should only be used for those with insulin-induced severe hypo if we cannot get venous access, so it's a backup really. Once the BMs, assuming the treatment is successful, once the BMs are above 4 and the patient is eating and drinking, we can give a 20-gram long-acting starchy carbohydrate, such as a 40-sip or bread or something like that, to try and maintain the blood glucose levels. If the patient is nil by mouth, or they've had more than 2 hypoglycemic episodes in 24 hours, then we can give a 10% IV glucose infusion at 100 ml an hour until the specialist can come and review. So hypoglycemia is a blood glucose of less than 4, and it's important that we treat this early and look for any nutritional or iatrogenic causes. If at any point we're struggling to manage diabetes, it's important to contact the diabetic team within the trust. And we should consider HHS if the blood glucose is greater than 30 and the pH and ketones are normal in an unwell diabetic patient. So that concludes our talk on diabetic emergencies. Thank you very much, and let us know if you have any questions.